right, let's talk about a real diagnostic chameleon, a disease that can show up with some of the most vague, non-specific symptoms you'll see, but leads to a diagnosis that is absolutely critical to get right. We're diving into gastrointestinal amyloidosis, and this is your high-yield guide, especially if you're in training, to help you spot it, diagnose it, and really understand what's going on. So here's our game plan. We're going to start with the basics. What in the world is amyloid? Then we'll focus on how it messes with the GI tract. After that, we'll get into the clinical stuff, the red flags you need to be looking for. Then we'll walk through the actual diagnostic journey from suspicion to proof. And we'll wrap up with the most important part: why figuring out the exact type of amyloid changes the entire treatment approach. Let's get into it.
Okay, first things first, before we can even talk about the gut, we have to understand the villain of our story. So what exactly is this stuff we call amyloid?
Now, I know this sounds like a textbook definition, but the key words here are insoluble and beta-pleated sheet. This isn't just some random pile of protein garbage. These are proteins that were supposed to be floating around doing their jobs, but they've misfolded and locked together into these incredibly stable, rigid structures. It's like microscopic concrete being poured between the cells of an organ, and as you can imagine, that seriously gums up the works.
And this isn't some new discovery. Way back in the 1850s, the famous pathologist Rudolf Virchow was describing this. I love this quote because it's so vivid. He described the deposits as having a waxy or lardaceous, as in lard-like, appearance. It just paints this picture of organs being infiltrated by this weird, fatty, waxy substance. So how does a good protein go bad? Well, it's a four-step process. You start with a perfectly normal, happy, soluble protein. Then, something triggers it to misfold into an unstable shape. Because it's unstable, it gets sticky and starts clumping together with other misfolded proteins. Finally, those clumps organize themselves into those super strong, insoluble fibrils that get stuck in tissues. The key here is that transformation from a helpful soluble protein into a harmful solid deposit. Okay, so now that we know what it is, let's bring this into our world, the GI system. There are actually dozens of different proteins that can form amyloid, but when it comes to systemic disease that involves the gut, there are really just a few main culprits you need to know about. These are the big three. This is your main lineup. First and most common is AL amyloidosis. The culprit protein here is an immunoglobulin light chain, and it's coming from a plasma cell disorder like multiple myeloma. Next up is AA amyloidosis. This is a reaction to severe chronic inflammation, like in rheumatoid arthritis or IBD. And third, we have ATTR amyloidosis, which comes from a protein called transthyretin. This can be hereditary or just a consequence of aging. When you're thinking amyloid in the gut, these three should be at the top of your list.
Now, you might be looking at this and thinking, okay, but how often am I really going to see this? And you're right, only about 4% of patients with systemic amyloidosis have GI symptoms as their main thing. But don't let that number fool you. For that 4%, the symptoms can be incredibly severe and really challenging to manage. So while it's not the most common presentation, when it happens, it's a big deal. So this brings us to the clinic. This is the practical part. When should that little amyloidosis alarm bell start ringing in the back of your head? What are the clues that should make you put this on your differential diagnosis? And here's what makes it so tough. The symptoms are all over the map. You can get an enlarged liver or hepatomegaly. You can get bleeding because the amyloid makes blood vessels really fragile. Motility can get totally messed up, causing anything from gastroparesis to a pseudoobstruction, or you might see malabsorption with weight loss. The key is that it's often a weird combination of these things that doesn't have another easy explanation. But there are a couple of classic, almost giveaway physical exam findings, and this is a huge one: macroglossia, or an enlarged tongue. This is especially common in AL amyloidosis. If you see a patient with a big, swollen-looking tongue, maybe with little indentations on the side from their teeth, you have to be thinking amyloid. It's a major, major red flag. And here's the other classic sign, again, highly suggestive of AL amyloid: periorbital purpura. People call it raccoon eyes. It's this spontaneous bruising around the eyes. It happens because those amyloid fibrils are infiltrating the tiny blood vessels and making them incredibly fragile. Sometimes even just coughing or vomiting can cause it. If you see this, your suspicion for amyloid should just skyrocket. Okay, so the clinical picture is starting to come together. You've seen some red flags, you have a suspicion. So how do we actually prove it? Let's walk through the path to a definitive answer. The question is simple. How do you go from, I think this might be amyloidosis to, I know this is amyloidosis? Well, there's only one way. You have to get tissue. Amyloidosis is, at its heart, a tissue diagnosis. You have to see it under the microscope. So, where do you get the tissue? You've basically got two choices, and it's a classic risk-reward scenario. The easier, safer route is an abdominal fat pad biopsy. It's minimally invasive, low risk, but the sensitivity isn't perfect. It can miss it sometimes. The other option is to go right for the affected organ, the gut, the kidney, the heart. That gives you a much higher chance of finding it, over 90%, but obviously it's a more invasive procedure with higher risks. Usually, you start with the fat pad. And once that tissue gets to the lab, this is the money shot. This is the pathognomonic finding, the absolute gold standard. The pathologist stains the tissue with a special dye called Congo red, and then looks at it under a polarized light microscope. If amyloid is there, it glows with this incredible, unmistakable apple green color. It's really beautiful, and it's definitive proof. But, and this is a huge but, seeing that green glow isn't the end of the story. It's really just the halfway point. Because a diagnosis of just amyloidosis is basically useless for treatment. You absolutely have to know what protein is forming those fibrils. And how do we do that? With this amazing technology, mass spectrometry. The pathologist can actually use a laser to cut out the little bits of green glowing amyloid from the slide and feed them into a machine that analyzes their exact protein composition. It's like protein fingerprinting, and it tells you with incredible accuracy what the precursor protein is. Which brings us to the final and honestly the most important part of this whole discussion, the clinical payoff. Why do we go to all this trouble to find the amyloid and then figure out its exact type? Because the treatment for one type is completely different and completely ineffective for another. So if the mass spec comes back and says the protein is an immunoglobulin light chain, you've got AL amyloidosis. The problem is a rogue clone of plasma cells. So the treatment is to go after that factory. You use chemotherapy or other targeted therapies to shut down the plasma cells that are churning out those bad proteins. But if the protein is serum amyloid A, you've got AA amyloidosis. Here, the factory isn't plasma cells, it's the liver overproducing this protein because of chronic inflammation. Giving this patient chemo would do nothing. The goal here is to aggressively treat the underlying inflammatory condition, the IBD, the rheumatoid arthritis, to turn off the signal. And finally, if the protein is transthyretin, or ATTR, it's a whole different playbook again. We now have these incredible modern therapies that can either stabilize the TTR protein so it can't misfold, or even use RNA therapies to silence the gene and dramatically reduce its production. 3 totally different diseases, 3 totally different treatments. So if you remember only one slide from this whole thing, let it be this one. Amyloidosis is not one disease, it's a whole category of diseases. The specific protein defines the disease type. That type absolutely dictates the treatment. And getting the type wrong isn't just an academic mistake. It can lead to giving a patient a toxic, ineffective therapy while their real disease progresses. So I'll leave you with this thought to take with you to the wards. We are in a new era for amyloidosis. We have targeted, effective treatments that can make a huge difference. And that raises the stakes for all of us to be better diagnosticians. So the question is, how can you start to incorporate this thinking earlier? How can you have a lower threshold to suspect amyloid in that patient with unexplained GI problems? Because for them, catching it early and getting it right can truly change everything. Thanks for tuning in.